ബഹുമാനപ്പെട്ട വൈസ് ചാൻസലർ ഡോക്ടർ മോഹനൻ കുന്നുമ്മൽ സർ, പ്രോ വൈസ് ചാൻസലർ ഡോക്ടർ വിജയൻ സർ, മറ്റു മാന്യ വ്യക്തികളെ, കേരള ആരോഗ്യശാസ്ത്ര സർവകലാശാലയിലെ സെന്റർ ഫോർ ജെറന്റോളജിക്കൽ സ്റ്റഡീസിന്റെ ആഭിമുഖ്യത്തിൽ നടക്കുന്ന കെയർ ഫോർ ഏജിംഗ് ഐ എന്ന വെബിനാറിലേക്ക് എല്ലാവർക്കും സ്വാഗതം. പ്രായമേറി വരുന്ന ലോക ജനതയുടെ സ്വാഭാവികമായും അസ്വാഭാവികമായും സംഭവിക്കുന്ന മാറ്റങ്ങളെക്കുറിച്ച് ആരോഗ്യ സർവകലാശാലയിലെ അഫിലിയേറ്റഡ് കോളേജുകളിലെ അധ്യാപകരുടെ ഇടയിൽ, അതിലൂടെ വിദ്യാർത്ഥികളുടെ ഇടയിലും സമൂഹത്തിലും ഒരു അവബോധം സൃഷ്ടിക്കുക എന്ന ലക്ഷ്യത്തോടെയാണ് ഈ വെബിനാർ ശൃംഖല സംഘടിപ്പിക്കപ്പെട്ടിരിക്കുന്നത്. അതിൽ അനവധി വിഷയങ്ങളെക്കുറിച്ച് ഓരോ പ്രഭാഷണങ്ങൾ നടക്കുകയുണ്ടായി. ഇന്ന് വളരെ പ്രധാനപ്പെട്ട ഒരു വിഷയമായ കണ്ണിനെ കുറിച്ചാണ്. എന്തൊക്കെയാണ് കണ്ണുമായി ബന്ധപ്പെട്ട പ്രായമായവരുടെ പ്രധാന പ്രശ്നങ്ങൾ, അവ എങ്ങനെ പരിഹരിക്കാം, അതിനെക്കുറിച്ച് നടക്കുവാൻ പോകുന്ന ഈ വെബിനാർ ഉദ്ഘാടനം ചെയ്യുന്നതിനും ഉദ്ഘാടന പ്രസംഗം നടത്തുന്നതിനുമായി കേരള ആരോഗ്യ ശാസ്ത്ര സർവകലാശാലയുടെ ബഹുമാനപ്പെട്ട വൈസ് ചാൻസലർ ഡോക്ടർ മോഹനൻ കുന്നുമ്മൽ സർ എത്തിച്ചേർന്നിട്ടുണ്ട്. അദ്ദേഹത്തെ ഞാൻ സെന്ററിന്റെ പേരിലും എന്റെ സ്വന്തം പേരിലും സ്വാഗതം ചെയ്തുകൊള്ളുന്നു. അദ്ദേഹത്തിന്റെ ഒരു ആശയമായിരുന്നു ഇങ്ങനെ ഒരു വെബിനാർ സീരീസ് നടത്തി ഫാക്കൽറ്റികളുടെ ഇടയിൽ ഈ ഒരു വിഷയത്തിൽ അവബോധം സൃഷ്ടിക്കുക എന്നത്. ഈ പരിപാടിക്ക് ആശംസ അർപ്പിക്കുന്നതിനായി എത്തിയിരിക്കുന്നത് ബഹുമാനപ്പെട്ട പ്രോ വൈസ് ചാൻസലർ പ്രൊഫസർ ഡോക്ടർ വിജയൻ സർ അവർകളാണ്. അദ്ദേഹത്തെയും ഈ പരിപാടിയിലേക്ക് സ്വാഗതം ചെയ്തുകൊള്ളുന്നു. ഈ പരിപാടിയുടെ മുഖ്യ പ്രഭാഷക ഡോക്ടർ പത്മജ കൃഷ്ണൻ മാഡം ജീറിയാട്രിക് കെയർ എന്ന വിഷയത്തിൽ ഫെബ്രുവരി 29 മാർച്ച് 1 കോഴിക്കോടുള്ള ബേബി മെമ്മോറിയൽ ഹോസ്പിറ്റലിൽ കഴിഞ്ഞ വർഷം നടന്ന 2 ദിവസത്തെ ശില്പശാലയിൽ ഒരു പ്രബന്ധം അവതരിപ്പിക്കുകയുണ്ടായി. അത് വളരെയധികം പ്രേക്ഷകരുടെ ശ്രദ്ധ ആകർഷിക്കുകയും ചർച്ച ചെയ്യപ്പെടുകയും ചെയ്തിരുന്നു. പത്മജ മാഡത്തിനെയും ഞാൻ ഈ വേദിയിലേക്ക് സസന്തോഷം സ്വാഗതം ചെയ്തുകൊള്ളുന്നു. കൂടാതെ യൂണിവേഴ്സിറ്റി സ്റ്റാറ്റ്യൂട്ടറി ഓഫീസർമാരായ രജിസ്ട്രാർ ഡോക്ടർ മനോജ് സർ, ഡീൻ അക്കാഡമിക് ഉണ്ണികൃഷ്ണൻ സർ, ഡീൻ റിസർച്ച് ഡോക്ടർ ഷാജി സർ, ഡീൻ സ്റ്റുഡൻസ് അഫയേഴ്സ് ഡോക്ടർ ഇക്ബാൽ സർ, കൺട്രോളർ ഓഫ് എക്സാമിനേഷൻസ് ഡോക്ടർ അനിൽകുമാർ സർ, സ്കൂൾ ഓഫ് ഹെൽത്ത് പോളിസി ആൻഡ് പ്ലാനിംഗ് സ്റ്റഡീസ് പ്രൊഫസർ ഡോക്ടർ രാജ്മോഹൻ സർ, സ്കൂൾ ഓഫ് റിസർച്ച് ഇൻ ആയുർവേദ ഡോക്ടർ സുധികുമാർ സർ, ഈ മേഖലയിൽ പ്രവർത്തിക്കുന്ന വിശിഷ്ട അംഗങ്ങളെ, ഇതിൽ പങ്കെടുക്കുവാൻ എത്തിയിരിക്കുന്ന എല്ലാ മാന്യ പ്രേക്ഷകർക്കും ഈ പരിപാടിയിലേക്ക് സ്വാഗതം. അടുത്തതായി ഉദ്ഘാടനം ചെയ്യുന്നതിനും ഉദ്ഘാടന പ്രസംഗം നടത്തുന്നതിനുമായി കേരള ആരോഗ്യ ശാസ്ത്ര സർവകലാശാല ബഹുമാനപ്പെട്ട വൈസ് ചാൻസലർ ഡോക്ടർ മോഹനൻ സാറിനെ ഞാൻ ആദരപൂർവ്വം ക്ഷണിച്ചുകൊള്ളുന്നു. സർ, പ്ലീസ്.
Thank you, Subhadra. Thank you so much. Respected Pro Vice Chancellor Dr. C.P. Vijayan, respected invited faculty, Professor Padmaja Krishnan, and esteemed faculty members and colleagues. I'm so happy to offer few words and also declare formally that the session inaugurated. In fact, I have been inaugurating such sessions, several such sessions, and I don't know whether this formality of inauguration is required at all. We have been conducting wonderful webinars on gerontological studies. In fact, we did as Subhadra was saying, we did a 2-day conference with the help of Baby Memorial Hospital in Calicut, 2-day conference. And our intention was to have similar meetings all over Kerala. But then suddenly COVID came, and then we switched on to the online programs. And initially we never knew that this is going to be successful. But now we have realized that this is a very good platform. This is a very good platform wherein you can disseminate knowledge. In fact, all the 313 colleges of KUHS is conducting their academic programs through online programs, and university has all designed and created a online education policy. So such things are coming. A policy document on online education has been created, and it has been approved by the academic council, and then so that university is going to have a online project education policy. And we have created programs in MOOCs platform, massive online open courses. So we have piloted one course and similar courses will be conducted. And gerontology is definitely one area where we are going to create a good course, probably for which a certification also will be there. In fact, we have been discussing with UGC. The person who is concerned with UGC, we had a discussion, and they have offered total support to us. So probably we may be able to give digital health content to UGC, so that that can be beamed all over India. And so such possibilities are coming. And of course, COVID is very bad. COVID has taken a lot of people, and all of us are taking vaccine and thinking that we may be safe. But then COVID has got certain positive things. That's why at 2 p.m. I can sit in the KUHS room, and Professor Padmaja can sit at her home. And so exciting that Professor Padmaja's mother is seeing this. Actually, the university is so thrilled that Professor Padmaja's mother is seeing this program, and we are so happy. And that is the positive side of COVID. So that otherwise we never would have thought this technology was available 10, 20 years ago. But then there is a time for every technology to take place, to come among the people. And maybe you may be knowing that India is going through a amazing transition. People say that the fourth industrial revolution is happening all over the world, and now we are jumping into fifth industrial revolution, where humanity is given more importance, where personal concerns are given more importance. And this webinar, if it helps our brothers and sisters who are aging and their visual problems, if that gives us some benefit to us, benefit to the people who are listening, then the university is so happy. The university is successful in that university has conducted a good program. Anyway, the great speaker is there, so why should I take her time? So I am stopping, and I formally declare that today's program is inaugurated. Thank you so much.
നന്ദി സർ. സർ പറഞ്ഞ പോലെ ഈ പ്രോഗ്രാം എല്ലാവർക്കും ഉപകാരപ്രദമാകട്ടെ എന്ന് ആശിച്ചുകൊള്ളുന്നു. അടുത്തതായി ആശംസ അർപ്പിക്കുന്നതിനായി ബഹുമാനപ്പെട്ട PVC ഡോക്ടർ വിജയൻ സാറിനെ ക്ഷണിച്ചുകൊള്ളുന്നു. സർ.
Honorable Vice Chancellor of Kerala University of Health Sciences, today's invited speaker, Professor Padmaja Krishnan, Dr. Subhadra, other officers of the university, and faculty members. As our Vice Chancellor correctly said, too much formalities are not required for an academic talk by an expert, but somehow it has to get started. So a formal inauguration and VC's inaugural comments are over. So I am not taking much time. I wish this program all success. Thank you very much.
നന്ദി വിജയൻ സർ. അടുത്തതായി ഇന്നത്തെ മുഖ്യ പ്രഭാഷണത്തിനായി ഡോക്ടർ പത്മജ കൃഷ്ണൻ എത്തിയിട്ടുണ്ട്. മാഡം ഇപ്പോ ഒഫ്താൽമോളജി ഡിപ്പാർട്ട്മെന്റിലെ HODയും പ്രൊഫസറുമാണ് MES കോളേജ്, മെഡിക്കൽ കോളേജ് പെരിന്തൽമണ്ണയിൽ. അതിനു മുമ്പ് മാഡം ഗവൺമെന്റ് മെഡിക്കൽ കോളേജ് കോഴിക്കോട് ഡിപ്പാർട്ട്മെന്റ് ഓഫ് ഒഫ്താൽമോളജിയിലെ HODയും പ്രൊഫസറുമായിരുന്നു. കൂടാതെ മാഡം എത്തിക്കൽ കമ്മിറ്റിയുടെ ചെയർപേഴ്സൺ ആണ് ബേബി മെമ്മോറിയൽ ഹോസ്പിറ്റലില്. അതുപോലെ തന്നെ കോൺട്രസ്റ്റ് ഐ ഹോസ്പിറ്റൽ കോഴിക്കോട് മെമ്പർ എത്തിക്സ് കമ്മിറ്റി അംഗവുമാണ്. മാഡത്തിനെ ഞാൻ ഈ വേദിയിലേക്ക് ക്ഷണിച്ചുകൊള്ളുന്നു. മാഡം.
Good afternoon, everybody, and thank you, Vice Chancellor, and all the people in the Center for Gerontological Studies who have asked me to speak on this topic, which is really very close to my heart. Is my mic, can you hear me? Krishnan thinks it's not working. You can.
We can hear very well, excellent.
Okay, thank you. So I'm going to start sharing my screen. Okay, fine. So I've been asked to talk about the problems and the solutions that are there for the eye as it ages. So the topic is caring for the aging eye, but it's not going to the next slide. Okay, fine. So before I start, I have no conflicts of interest, though I must confess the initial PowerPoint I made, last night I deleted it all because I've always made PowerPoints pilfering slides from the net. And because this is going to be published and because of the fear that I don't know whether there would be copyright issues, which I would be violating. So I've finally acknowledged up to date, which my husband subscribes to, and the other photographs are all from our personal collection. So there may be people in the family who will recognize a lot of things. My topic, like I said, is caring for the aging eye. And as an ophthalmologist, I guess my duty is to look after the eye. But over the years, I've realized that the eye is but an appendage of a person. And therefore, my talk, and there is a subtle but very vital and valuable difference between caring for the eye, which is aging, and caring for an eye in a person who is aging. To begin with, let me ask, is there any need to care for the eye? There's a popular feeling that you can spoil your eye by overuse. My question to that is, would you similarly think that if you've been eating and tasting, you lose your taste? Or if you've been smelling, you will lose your sense of smell? I guess for hearing, loud voice noises are supposed to affect your hearing. But my point is the eye is meant to be used. And I guess you can spoil all of these by abusing them, but normal use should not affect it. When our eyes are open, light, whether we like it or not, falls and is focused onto the retina. And whether I give importance to what I'm looking at or I'm daydreaming, not thinking of what I'm looking at, it makes no difference to the eye. So ultimately, seeing is all actually in the mind. And especially, as you all know, I used to think also till recently, that dreams were mainly feelings, that you went through an experience. But recently I had a dream when vividly I saw people, I saw colors. So I firmly believe that the brain can ignore the light that is getting into the eye, and the brain, like in every dream, can generate the things that you imagine that you are seeing. So ultimately, it's not the eye. The eye is just an organ. It just converts the light energy into an electrical impulse, which the brain then interprets. So my first point is, I don't think you can spoil your eye or misuse it and then lose vision just because you've used it. Contrary to many popular beliefs that if you don't care for your eyes, or if you don't look after your eyes, or if you don't husband your vision as you get older, you're going to lose it. So coming to that, what exactly is vision and what is sight? Vision and sight, and what is the purpose of seeing? Ultimately, if I ask, why do we need vision? I want to argue that vision is all about helping us to live in this world. And the vision that I need is what I need to perform. And when I get old, it may be I don't go to work, but I would still like to read, I would like to walk, I would like to cook, and in my case, I would like to knit. So I want the vision to enjoy my life doing what I would like to do. However, this is how we define vision. Now, these are the charts that we use, and I'm accepting that I need these to assess, to grade, and to certify vision. But the big difference that I have realized over the years that vision does not reside in any of these charts. And in this context, I must tell you the story of one of my patients who was a very high myope. Now, myopia or short sight varies, and there is a type of myopia which is actually a disease where, quite apart from the myopia, the retina starts failing early. And because the retina is not working, glasses do not improve the vision. So I had this lady with a very high, many of you may be myopes, but my patient had a myopia of about 30 diopters, which would be way above what any of you have heard. And she came to me saying that she had lived with that vision, and she wanted to know if I could do anything to improve her vision. I had no hope whatsoever, because I know that that level of myopia with changes in the fundus will not improve with any kind of glass. Anyway, I did what I normally do, tried to estimate her refractive power, called her back, and then without any hope, I started putting lenses into my trial frame and saying, okay, let's see what I can do for you. Let's see if you can see anything. And way below what her value was, around 6 diopters, she told me, stop right there. I can see now. So I said, can you see my chart? She said, look, no, I don't need to see the chart. I can see you. That is all I want. That's the vision I want, which she didn't have till then. So I'm trying to say that vision is definitely in the mind. Vision is what I need to do what I want. It is hardly, I don't carry these charts at home and see whether I can read. As an ophthalmologist, they're valuable. I need to know how far or close you are away from what I consider normal. But I don't need to make everybody read 6/6, N6 and have normal color vision and make them feel that if they fall short of this, they are in some way inferior or abnormal. So now let's go to aging. What happens as we age? The first thing is that our appearances change. We have all the discomforts of aging, as all of you might know, as I've begun to realize, the aches and the pains and the stiffnesses that come with aging. And we lose function. We are no longer as smart in any of the things that we used to do. But that doesn't mean that we can't do any of these. We can, but probably we are not doing it as far or as effectively. I used to be a really fast walker, and many people had commented on it. Well into my 40s and 50s, I used to race down corridors. Now, as I walk, most people overtake me. But that doesn't mean I'm not walking. I'm still walking. So I don't walk as fast, but I can. And I would like to extrapolate this to what happens with the eyes when they age. There will be a change in the appearance of the eye and around the eye. There will be discomfort in the eye. And most important, the function of the eye, which is to see, can get compromised in more than one way. Some of them not so serious, some of them potentially so. So here, I first start with change in appearance. These are the people I've known all my life. On their wedding day, and then some 65 years later, and you can see they've aged. The lines are there, the pouches are there, the eyes are sunken, but I maintain that they're looking as beautiful in their 80s as they did in their 20s and 30s. And so cosmesis is what you want. I'm very happy looking at old people's faces. They give me a lot of joy. And as an ophthalmologist, I have to deal with many old people. But if you want wrinkles ironed out, if you want pouches taken off, if you want sunken eyes filled, that we have a whole specialty of oculoplastics, and you really don't have to worry. They're going to make you look as good as you were in your 20s and 30s. But personally, to me, there is a grace and a beauty in the aging face, which getting rid of really doesn't make all that much sense to me. But along with this, the changes in the appearance could in some ways affect the function. And here you can see that the eye is small. Why? Because the upper lid has come down. In the earlier picture, in fact, you could see the furrows on the forehead, which came up because of an attempt to open the eye. So this drooping of the eye, which we call a ptosis, occurs as we get older and the lid skin becomes lax, comes down, and this could be a problem. It could actually take away your vision because the lids are closing the eye, and it then necessitates that you lift your chin up, and this is bilateral, usually could be severe on the two sides, and lifting up the chin will make the eyes come down and you actually peer under these ptotic or drooped lids. And there is a constant effort to open these eyes by lifting the brow, because the lid is attached to the brow, as is the forehead. So So lifting the eyebrow by using these muscles, which classically, I mean, as you get older, including me, I have these sunken eyes, I have slightly smaller eyes, and the only way I have to see would be to raise my lid. So I said that changes in appearance are very much cosmetic, the wrinkles, the crow's feet, the furrows, the lines, the loss of the cheeks, the smoothness, none of it should be an issue, but certain changes could actually affect the vision as well. Now, when it comes to the eye becoming uncomfortable, the commonest cause is because of lack of tears. It's partly that the eye is not secreting enough tears. It's partly our lifestyles that have made our eyes become dry, as I will explain. So dry eye is a cause of symptoms which are so similar to what you would attribute to asthenopia or eye strain. But I want to first state very clearly that asthenopia occurs in young people with uncorrected refractive errors. It doesn't occur in the old person. So the older person who complains of discomfort in his eye, who says the eyes become gritty, the eyes water, the eyes become red, and after rest, he feels much better, and that all these symptoms come on towards the end of the day, which in a younger person, I would immediately diagnose as due to the need for glasses. In an older person, I can assure you, and the older person also has the feeling that what I need to do is change my glass and these things will go away. Believe me, they won't. The reason why they have come is because today we spend most of our time using our eyes. And when we concentrate with our eyes, we stop blinking. And when we don't blink, the eyes remain open to the atmosphere, the tear film in front of our eyes dries up, the surface becomes irregular, you lose vision, the vision blurs, because what we actually see through is the tear film in front of the cornea, which acts as a smooth, absolutely well refracting surface. So the loss of the tear film in front of the cornea, the changes to the surface epithelium will cause discomfort. You lose epithelial cells, you feel that there's a foreign body in the eye, and paradoxically, the main lacrimal gland, because of the irritation, secretes tears so that the eyes actually water, but there is no water all the time covering the surface and keeping it smooth. And this again is akin to what's happening to all our skins. Our skins become thinner, we lose our sebaceous glands, our skins become dry. In the same way, the eye needed water, not lipid, and the eye, because of dryness, becomes uncomfortable. And if any of you have these symptoms, I advise you strongly to start blinking, to just open and shut your eyes while you are in front of your devices. And believe you me, it will make a world of difference to the symptoms that you have. So dry eye symptoms are almost universal. We women bear the brunt of it after menopause. We have more of it than, because androgens are supposed to be in some way associated with dry eye. So dry eye is commoner in women, dry eye is commoner after the menopause, and it is very, very common. But the amount of trouble that it causes is very variable. Like in everything else, there are people who will tolerate discomfort, who will not be bothered about it. And very often it's when I make them aware that they then start complaining bitterly, because till then they've taken it. I mean, it's been there, it's not been troubling them. So if you've had no trouble, don't worry about dry eyes. But if you have the symptoms I said, consider dry eye and start blinking. The other things that I have mentioned are changes that occur within the lid. Now these changes, that is the lid margin rolling out, or the margin of the lid where the lashes are, turning inwards towards the eye so that the lashes rub on the eye, will both cause watering irritation. And both these are because of laxity of the lid skin, laxity of the tissues of the lid, making the lid. And this usually happens in the lower eyelid, and it's worsened, especially ectropion, by pulling on the lid. So when the eye waters, you keep rubbing it downwards and you pull the lid further and further. You increase the laxity, you increase the tendency for this to occur. So like we would tell our patients, when you want to dab your eye, dab them upwards rather than downwards. So wipe your eye that way, don't pull it down. Blepharoconjunctivitis is a type of chronic inflammation of the lid margin and the conjunctiva, which could occur at any age actually, but tends to occur in older people, especially in diabetics. So I've dealt with a few of the discomforts. The one I really need you to take home and take to your hearts is the very common dry eye, which is usually mild and very easily managed. Now I get on to the real nitty-gritty of my talk, which is what all of you must be thinking of: aging eye, losing vision, not being able to see. So for you to understand why do we stop seeing or don't see as clearly, I would like you to remember that the light from whichever object has to travel all the way through the eye and focus on the retina, where this clear image that is formed stimulates certain receptors here which receive the light and then convert it into an electrical impulse, which then travels down this main optic nerve all the way to the back of the brain, where you have the centers that can interpret what you're seeing. So the first requirement for you to see clearly is that all these areas, what we call the media through which the light travels, has to be clear. The cornea must be clear. This empty space, which is normally filled with water, has to be clear. This opening in the iris, which is the pupil, must be clear. This crystalline lens, which helps to focus, should be clear. And this jelly-like glassy substance, which is present between the lens and the retina, filling most of your eyeball, the vitreous, has to be clear. Apart from that, the light that is coming has to be bent, has to be refracted, has to be converged by the two main refracting surfaces, these two convex lenses, the cornea and the crystalline lens, which will form a real but inverted image on the fovea, a tiny little image on a pinpoint area, which we then see in all this glorious color, shape, form, and size, which again, I repeat, had nothing to do with this little eye, had everything to do with our brains. Now, I've shown here light that is coming in not only straight lines, but parallel lines. Unfortunately, light never travels in parallel lines. It travels in straight lines, but it radiates either from a source or from what you're looking at, where the light is being reflected. Light goes out in all directions. But when light is coming from far away, I can take it as virtually parallel. And usually we say that our eyes are focused as if for distance, as if for light that is coming from far away. Now, what happens when light comes nearer? As light comes nearer, the parallel rays will actually now become more and more divergent. And if my retina is in the same place, the first requirement for me to continue to focus the image on the retina, and the nearer it comes, the more the divergent the rays, the more the power has to be increased. And that increase in power is brought about by changing the convexity, the sphericity of this lens through the action of these muscles and these ligaments, or finer than hair ligaments, which attach the lens to the ciliary body. So what have I said? I've said for you to see for distance, all these have to be clear and the light should be refracted properly. But for you to see for near, this will not hold. The power has to be increased by increasing the power of the lens. So now let me go to, let me start with the commonest, the universal problem that all of us are going to face sooner or later, which is presbyopia. Presbyopia literally translates to the vision of old age, and the crystalline lens, as we get older, loses its elasticity. It becomes more and more rigid, so that it is no longer able to become more convex or become convex enough to focus the light that is coming from near. And when it starts, you can still see far away. When it is extreme, you cannot even see closed. I mean, you can't see even at that distance. So you can initially see at arm's length away, and then you find that you don't have the power to see even that. So that is presbyopia, which all of us experience around the age of 40. Typically, I'm sure all of you who have experienced it would know, symptoms are worse in the morning. When you wake up in the morning after a night's rest and try to look at your watch, try to read something, you find that everything is a blur. Whereas formerly, you were seeing it immediately. As soon as you looked at it, you saw it clearly. But now it takes a couple of minutes and then slowly you start seeing. That's because the now less elastic, more rigid lens is taking its own time to mold into a more spherical shape. So that is presbyopia, which is only related and age-related. I could even call it a physiological change, a change that occurs in everybody. Never mind whether you're emetrope, myope, hypermetrope, the symptoms might vary, but the rigidity of the lens, because newer lens fibers are added throughout life, the older lens fibers are compacted and they become rigid. And this rigidity of the lens increases at the same rate in all of us. So that my students are very fond of telling me that at 40 you need a +1, at 45 you need a +1.5, at 50 you need +2, and so on. It's so universal. It's astonishing that the way we age, as far as the lens goes, is similar. But the next aging change in the lens is not so. This is now the lens having lost its clarity. So instead of a clear, I love to teach, and I don't know whether the things I say would make, would seem very silly to my mother, who is a physicist. But anyway, so when I see something white, I see it white because all the light that fell on it came back to me, which means that when I see this white cataract, I know that no light goes into the eye from those white areas, and from the gray areas, very little is going through. So what is a cataract? Cataract is opacification, is loss of transparency of the normal crystalline lens, so that the lens, instead of sending light into the eye, now sends the light back to me. So what I would love to see is a black pupil, not because there is a black lens there, because all the light that fell in the pupil now went through into the retina to help you to see. So this is a cataract, and in the initial stages, it's the hardening of the lens that changes, and then the lens fibers get denatured and the protein changes from soluble transparent to insoluble opaque. And depending upon where these changes occur, if they occur only in the periphery, you still see very clearly. So people will tell you, Timirathinda Todakana, yes, but you are seeing still perfect, 6/6. Or you might not see 6/6, but when they give you a power, you start seeing 6/6. And patient after patient will ask me, Dr. Timirando. And to me, of course, it's a silly question, because everybody after a certain age is likely to have some opacification somewhere. But that's not what we are concerned with. When the patient asks me about Timiram, what he's worrying about is losing vision. And that loss of vision will occur only if and when this opacity occurs in the center. Because this is a dilated pupil, I need this central area clear to be able to see clearly. And the other thing is that when cataract is forming, the changes in the lens also cause a refractive change. So you can become long-sighted or short-sighted in early stages of cataract. Again, something that many people have experienced. They start wearing glasses at 40 for presbyopia, and come 50, 55, they suddenly find that even without their glasses, they're seeing fine. They've lost some of their distant vision, which doesn't worry them. Again, distant vision loss, which occurs gradually, brings your horizon closer, and you just assume that horizon is what it is for everybody. And the thing that, again, I love to say is that for each of us, the normal is us. The way I look, the way I think, the way I walk, the way I talk, the way I dress is the normal. And sadly, anybody who doesn't fulfill these normal parameters that I think is abnormal. So that every myope, till I can show him that he could have seen much better, assumes that what he sees is what everyone sees. Or like my myopic daughter, who when first corrected told me, Ayyo, was that white thing a flower? I didn't know that. She looked at the bush across the front door and said, I never realized that was a flower till now. So after that, now she knows how well she could see. She never goes anywhere. The morning, the first thing she does after, I think even before brushing her teeth, is to wear her glasses. So what happens when you develop cataract? On the left panel, I have fairly clearly taken photographs. And on the right side, I have the same photographs, which are not so clear. Of course, these are my husband's photos, which he didn't focus well enough or he didn't expose or whatever. I'm no photographer, but this is what happens when you develop cataract. The whole picture is now blurred. Everything you're not seeing in sharp focus, you're seeing it blurred. And as the cataract worsens, you see less and less. So only the areas where there was maximum contrast, you're picking up. So this lack of contrast in cataract is another problem, which despite patients seemingly having good vision on our Snellen's chart, where the contrast is extreme, where the bright and the dark are poles apart, could be better than the vision the patient has in a dimmer light where the contrast is less, where his cataract makes that contrast even less because he cannot differentiate the borders of objects. The diseases that take away vision, the commonest is cataract. So cataract again is related to aging. And like many of us will develop white hair early and many of us will retain our black hair later, cataracts also occur at different paces in different people. And some people develop it early, some people develop it late. But the popular saying is that if you live long enough, you will certainly develop a cataract. Quite different from this is the next disease that all of you I know live in dread of, primary open-angle glaucoma. The word glaucoma itself conjures up such feelings of fear and blindness, which is really not indicated, as I will tell you in a minute. So visual loss in cataract, the blurring that occurs slowly and progresses gradually. A similar visual loss will happen in glaucoma, only the difference being that what you're going to lose slowly and gradually is the central vision, by which time you have lost most of your surround vision. So when you're looking at anything, you not only see the thing you're looking at, but you see your field, all the things around you, not so clearly, but you need that visual field if you have to walk about without bumping into things. And glaucoma slowly takes away the surround, the periphery, and retains the center, sometimes to astonishingly normal values. I will have just a tunnel of vision just around fixation, but that vision might be 6/6, whereas all around here, the patient is seeing nothing. And this, of course, is as if you're looking through a tunnel, because our visual fields fan out. So I can see less close to me, but further away, I can see my horizon just opens up. Whereas if I have glaucoma, whether it is here or far, I see only in the center. I see as if I'm looking through a cylinder or looking through a tunnel. The next difference between cataract and glaucoma is that glaucoma blindness, unlike cataract blindness, is not reversible, because the blindness occurs because of damage to the optic nerve, and the optic nerve is a part of the brain. And once it's the white matter in the brain, and once it is destroyed, once it is damaged, once it dies, it does not regenerate. So unlike cataract blindness, where the vision could come down to just seeing light barely, and the next day I can improve his vision to 6/6 as if by magic, in glaucoma, the best I'm hoping for is that when I see my patient, I will help him to retain that vision for the remainder of his life. So that is my goal, to slow the progression of the disease, to decrease the visual loss to the age-related visual loss, because both the retina and the brain will also age with time. And we don't, like I said, need necessarily the vision of 20 to live the remaining 20 years of our lives. We need far less to perform. So glaucoma, the fear of glaucoma that all of us have, which we don't want to therefore miss and not treat, is the fear of missing it and a patient going blind. The net result is that probably we are over-treating, including me. We are probably playing safe and over-treating glaucoma than it needed. And sadly enough, despite all this, there are people who don't come to us and who go blind all the same with glaucoma. The third conditions which would take away. Now, whenever I say I can't see clearly, I mean I can't see clearly where I should normally be seeing clearly, which is why the glaucoma patient complaining of loss of vision is very, very late into the disease. Or it is because other people think he's blind because he bumps into them and people get irritated. Whereas they feel that they're seeing clearly, but they're not aware that there were things on the side. The reverse happens in this condition. Here, the periphery is normal, and the periphery might remain normal, but what you lose is the center. The center of the retina is the macula, the centermost point is the fovea. These are the only places where you can see sharply, clearly, and you can see colors. The periphery sees color, but not as clearly as in the center. So the third lot of diseases that again occur as I get older could be related to changes that occur in the macula. And there are two of these. One is diabetic maculopathy, that is diabetes mellitus affecting the blood vessels within the retina and decreasing the blood flow to the center of the eye, while the surround is less affected. But diabetic retinopathy is a global disease. It affects all of the retina. So when the patient complains of defective vision, it's because his macula is involved, but he could easily have diabetic changes elsewhere as well. Quite different from this is age-related, what we formerly call senile macular degeneration, where the change is limited to, it starts in the macula, again progressive, but it remains there, that it might take away the central vision almost completely so that you can't read. And in the initial stages, just magnifying and using the surround could help you to identify. But as you get older, you lose the center. But the surround, the field of vision that I was talking about, is always there. And in this context, again, I have to tell you the story of a friend of my father-in-law's who had macular degeneration. It's a very, they were colleagues in the secretariat. And so after they retired, obviously one of their fascinations was in reading, discussing books, watching television. Those were the days before we had electronic devices. And then suddenly this gentleman found that he couldn't read as clearly. And he found that glasses were not improving. And this slowly got worse and worse till he couldn't see anything with the center. But he used to stay far away from where we stay, and he had to change 2 buses to get here. He regularly came to see my father-in-law on his own. All he needed was somebody to tell him where that bus was going. He could walk on the road because he had field. He could cross the road because nothing would hit him. He knew that there was something coming. So the field was normal. He could perform normally. He couldn't read what was written. And when he came into our living room, he would not know who entered. So till I started talking, he wouldn't even know that I was there. I mean, he would know somebody came, but he wouldn't know it was me. So macular degeneration is a disease which takes away the center, but doesn't necessarily make you blind in the meaning of totally unable to perform. I find my husband has altered slightly the pictures, but anyway, these are fundus pictures of diabetic retinopathy. And what I want you to appreciate is that changes occur all over. Changes occur in the center, in the macula. And as these changes increase, now all these changes that I'm seeing in the periphery are because the capillaries have been damaged. So the peripheral retina becomes hypoxic. The peripheral retina, because of hypoxia, secretes substances that cause the formation of new vessels. So this is the normal vascular tree. Here I can see fronds of vessels, which are abnormal. And these vessels are likely to bleed at any time. And when they bleed, they fill that jelly, the vitreous, with blood and take away. So then the light cannot go in and you lose vision suddenly. Diabetic retinopathy is one of my favorite, how do I say, campaign stories anyway. Because I firmly believe that diabetic retinopathy should have been prevented. What defines diabetes mellitus is the blood sugar. And however we argue it, the changes that I'm seeing in the vascular network must be related to the blood sugar level. And therefore, the higher the blood sugar level, the longer that blood sugar level has stayed like that, the greater the chances of capillaries being permanently damaged, of new vessels forming. And when we get to these stages, we are not able to reform. As of today, we cannot bring back the capillary bed. Blood supply, if it's the main arteries that are blocked, not here, maybe in the heart elsewhere, you can bypass the block. There is no way as of today to reperfuse a tissue where the capillaries have been permanently lost. And that is what we need to prevent. And that we could prevent if we asked that these patients controlled their diabetes from the word go. There are only two sets of people that I frighten today. Patients, poor people who have already lost vision and are worried about it. One is the glaucoma patient who feels no different whether he treats himself or doesn't. And the other is the diabetic. In the initial stages, I can see changes in the retina, but he feels fine. He can see normally. And everybody who comes to me at stages like this, which then I have to treat by something which is as bad as the disease, by destroying all of the peripheral retina so that the peripheral retina is no longer capable of producing the substance that makes for these vessels. Here I am. I've burnt off all of the peripheral retina in the interest of retaining the center. And at this stage, they come and say, I had a person, and unfortunately, let me say that also. Diabetic retinopathy almost always goes, bad diabetic retinopathy goes with nephropathy, because the capillary changes that we see in the retina are identical to those that you see in the kidney. So we have again and again poor people who come to us in their 50s and 60s when they still should be productive, begging us to reverse, to do something. And I remember, again, this is a favorite story, which I have to repeat time and again because it's made so much of an impact on me and the way I practice. I had this patient who said, Kenjita paraya doctor, engenengilum kaazhcha thirichu tharanam njan endu venengilum tharam. By which time he's gone to the retina specialist, he's had laser photocoagulation done, but his retina is so bad that no vision has come back. And then I asked him, and then he says, so I said, look, it's very difficult because the retina, once it's stopped functioning, I can't bring it back. Then he asked me, Formerly, I used to think, why make them feel guilty? So then I asked him, sugar? And it's actually with a matter of pride that they often tell me, they're actually proud as if they're marks that they've got. And then to this particular man, I said, and immediately he said, Doctor, so now what I tell every diabetic I treat is, neither you nor me wanted the disease. But having it, if you don't want later to develop complications for which I have no cure, I might decrease the effect of the complication, I will never be able to bring you back to what it was earlier, then please control your diabetes now. And I tell the story of this man and I say, Nale, if you come back to me with complications, you certainly cannot tell me, Ariyatha karanana, arinirnocha, I would have controlled my diabetes. This last picture I have is of an even worse type, the end stage of this, where the retina is off, where fibrous tissue has formed, and in these, there's a great chance that along with this, there's the worst type of glaucoma, neovascular glaucoma. Mind you, the progression from this to this to this is not very quick. It takes years. So my thing is that from the word go, before change is developed, and there are studies that show that good diabetic control in the first 5 years of diabetes go a long way to preventing or delaying the onset of diabetic retinopathy. That at that time, when actually you might be seeing good and feeling good, that is when you should make sure that your blood sugars were normal. This is macular degeneration, and we have two types of macular degeneration. One which is dry, where again the visual loss is like in cataract or glaucoma, gradually progressive and painless. And this one where new vessels like in diabetes form under the retina and they bleed, where the vision is lost slowly to begin with, and when this bleed or leak from the vessels occurs, there is a sudden worsening of vision. So macular degeneration, I'm sorry to say, there isn't very much that we can do for this type of dry macular degeneration, despite what we have been trying. There are theories, there are vitamins, there's lutein, zeaxanthin, all sorts of studies going on, none of them very conclusive, because like with cataract here also, even preventing cataract, problem is cataracts and macular degeneration are going to progress at different rates in different people. So we can't say whether the progression was slowed by the drug or it was a natural slowing of the progression. So macular degeneration, the good news is that it's definitely related to ultraviolet oxidative stress damage. And in our population, where cataracts are more, they seem to protect from macular degeneration. Whereas in the temperate areas, they live longer, they don't develop cataracts, but macular degeneration is much more of a problem in their population. For me, macular disease causing loss of vision is much more likely to be diabetes, especially with the diabetic epidemic that we have now around us. I'm sure I lost a slide. Yes, I lost a slide, because there was a slide which said that the causes for visual loss, the ones that I described in decreasing order of what I would consider their frequency: presbyopia, cataract, glaucoma, diabetic maculopathy, and finally macular degeneration. Those are the more common ones that I would get to see. But these ones that I'm talking about now are the more devastating ones. Fortunately, they're far more likely to occur in one eye. They're related to the diseases the systemic diseases that you develop as you get older: diabetes, hypertension. They're all related to either the blood not coming into the eye so that the retina infarcts, or the blood not going out of the eye so that the capillaries feel the brunt and they bleed. Ischemic optic neuropathy is again a disease where the blood supply not to the retina but to the optic nerve is suddenly compromised, and the main optic nerve then infarcts. So all these three can cause sudden loss of vision, but this and this will cause profound, very severe loss down to perception of light or less. And both these, unfortunately, have poor prognosis, because like I said, the retina is part of the brain, and we need to see these people really fast, the retinal artery occlusion people, really fast if we are to reperfuse. Whereas in ischemic optic neuropathy, which is usually due to a vasculitis, I can do nothing. The vasculitis has narrowed the vessel, there has been a clot forming over that, the vessel has thrombosed completely, there's no blood going to the nerve, and the nerve has infarcted permanently. Whereas here, if I see it within 6 hours, there is some chance. So some people with both these conditions might develop episodes of what we call amaurosis fugax, that is fleeting blindness in one eye. And to all these people who develop this, they know that in a little while, the vision will usually come back. But if the vision doesn't come back, they need to come and see us as early as possible, because if it's an arterial occlusion, I have some hope, whereas here I have little hope, but I have the option of preventing further morbidity. Now, my grandmother was one-eyed. She'd lost vision in one eye from glaucoma very many years ago. And when she was living with me, after she had a bath and breakfast, she was in the habit of reading the holy books. So I was on leave that day, and I was walking around doing something. And she told me, Papa, I cannot read. So I said, Muthushi, why you were reading just now? She said, no, Papa, I cannot see. എനിക്ക് ഒന്നും മനസ്സിലാവുന്നില്ല കുട്ടി, ഞാനിത് ദിവസവും വായിക്കുന്നതല്ലേ, I cannot see. Again, I told her, Muthushi, ഒന്നും കൂടി നോക്കൂ, എങ്ങനെ പെട്ടെന്ന് കാണാണ്ട് വരുമോ? Because that's the other problem all of us doctors have. Disease occur to our patients. They somehow, we assume, don't occur to us or our relatives. Either we go one to the other extreme and assume that we and our relatives have the worst possible forms of the worst possible diseases, or we assume that how could it happen to them? Not likely. So then when she told this to me for the third time, I tried to make her count my fingers and found she wasn't seeing. And then I ran down, picked up my ophthalmoscope and looked in and found that the artery supplying the macula, one half of her retina, was not having any perfusion from the artery. God blessed me and my grandmother, because I did what we do for arterial occlusions, which is massage the eye. And mercifully, within the next 5 minutes, she started seeing again, and she had that vision all her life. So this is arterial occlusion. If I was at work, she would have told me only when I got back from work, by which time it might have been late. But so anybody who complains of amaurosis fugax, what I advise is, look, if it comes back, you're fine. There's nothing I'm going to find either. The artery has opened up. It was only a spasm. It's come back. You're seeing. But if it persists, you must, never mind whether it's night or day. At the Government Medical College, Calicut, we have PGs on duty just to tackle these kind of emergencies. So please go and see. So these two are bad, retinal artery occlusion and the ischemic optic neuropathy. The one in the middle is not so bad, because even if capillaries bleed, if the capillary network recovers, if it reforms, vision can come back to fairly normal levels. This was my husband's request also, that maybe you would like to see these. So this is an infarcted white retina. This is a retina where the capillaries have bled. This is called the blood and thunder or fiery sunset or splash tomato ketchup appearance, which we keep asking our undergraduates to learn by heart without realizing that when you look at this, that's what it should have suggested to you. And this is the ischemic optic neuropathy, where the optic nerve head has actually infarcted. Now, retinal detachment, which is the last thing that I put up there, does not necessarily occur in older people. It could occur in anybody, but it is related to the peripheral retina becoming weaker. It is related to the jelly that is attached to the retina coming away, which is a posterior vitreous detachment. Now, unfortunately, again, when you hear the word detachment, everybody panics. But retinal detachment is a totally different kettle of fish from a vitreous detachment. A vitreous detachment occurs in all of us as we age, because that's part of the aging changes in the vitreous. But the vitreous, even if it detaches, remains clear. But some fibers within the vitreous come together so that you see these fragments floating about in your field of vision. And the vitreous that has collapsed, which has come away, that is the detachment from the back of the eye. When you move the eye, goes and hits the eye. Again, a symptom that many of you might have experienced. Stimulate the retina in any way, it will respond by seeing light. So you might see a flash of light, you might see floaters. Those are the normal aging changes in the vitreous. And in a few of those people, that vitreous pulling on the retina, as is happening here, has actually torn the retina. And then the vitreous fluid has actually gone through this hole. And this, the inner layer of the retina, has now separated from the outer layers, which is a retinal detachment. So retinal detachment is a cause for sudden loss of vision. My husband, again, is impressed by retinal detachment cause of visual loss. Certainly is, but it has nothing to do with aging. It has to do with weak retina in the periphery associated with myopia, or if the retina is not weak, it is trauma. Like if my bone was not innately weak, it's injury that will break it. In the same way, it may be a severe injury could break the retina, or it could be a weak retina where trivial trauma, or even seemingly with no trauma, the retina could break. And when you have retinal detachment, the fluid collects in one area and then seeps slowly towards the center. So you have this experience of a curtain rising before or falling from above before your eyes. So the way the vision is lost in a retinal detachment is like this. It starts from the periphery, because that's where the fluid is going to collect, and the hole anyway will form in the periphery where the retina is thinner and sometimes weaker. This is not to do with the eye, actually. Again, a request from my husband that you could have visual loss, not from the eye, but anywhere along the pathways beyond the eye. So you have the nerve, you have the two nerves joining together, and the purpose of them joining together is that your brain, like for everything else, your right brain sees the left side of your visual field, or here the right side of your brain sees the left side of your visual field, and the left side of your brain sees the right side. So in the same way, if you have damage to the left side of your brain, the loss is going to be on the right side of your visual field. Again, so here I'm saying that once it goes beyond the optic nerves, as you can see, the visual loss will not be in one eye, it will be in both eyes. And this could occur at different parts of the visual path. So I've finished telling you about the problems, at least some of the problems related to aging, which I thought might be relevant and useful. And now I have to go to the solutions. So what can we do for these people? Of course, these are the usual things that I would do, no? Including my mother, when I decided to be an ophthalmologist. The first thing she said, oh, appa papa ini naale thottu ido nanna ado nanna nu chodichondirikkalle adaville pani. Honestly, when I started practicing, most of our practice was prescribing glasses, and prescribing glasses was asking which is the lens with which you see better. But over the years, this has been delegated to optometrists and opticians, so that many of us no longer bother with what we consider a chore, but which I maintain is best done by us than by anybody else. And again, I have a story. I had this very senior consultant who was a good friend and a patient of Krishnan's, not mine, who used to come and talk to me. I mean, he was a family friend, so we used to spend time talking. And then one day he said, you know, I have a problem. I'm not seeing like I should. And I've been told that I have cataract and I need surgery, but I'm not so happy to get it done. I just wondered, could you check how much cataract I have? And then I found that if I changed his spectacle lens, which he told me was changed just a few days ago, I don't know whether the power changed because his diabetes was uncontrolled at the last examination, he improved to 6.6. And again, I'll never forget what he said. Oh, ippalana manslaye that you are a real doctor. I never realized, oh, you for me now, you are the best doctor. All of them told me there's nothing we can do other than operate. And look at that, like magic, you have brought my vision back just by changing my spectacle. So again, there are stories. My living this long has helped me to appreciate ocular disease and manifestations in all their myriad variety. So spectacles, where will I use? I will use in the older person, obviously, for presbyopia. I will use it in the early stages of cataract. And if it's a spectacle, I'm able to correct the vision to the level that the patient needs, I would still consider a spectacle a good option for a patient who, for whatever reason, isn't yet ready to undergo cataract surgery. Of course, when these people undergo cataract surgery, they are going to find that they see so much better than any spectacle they ever saw with. So people who are frightened of surgery and then finally they find the spectacles are not doing them enough, and then they get operated, and they come back and say, "Ayyo, ഞാനിത് എന്നേ ചെയ്യായിരുന്നു. If I knew that this is the difference it would make to your eye." So I tell them, look, if you do it, it will definitely improve. Then they tell me, പക്ഷെ ഇപ്പം എനിക്ക് പ്രശ്നമില്ലല്ലോ, എനിക്കിപ്പോൾ ഈ കണ്ണട വെച്ചിട്ട് എനിക്ക് വേണ്ടതൊക്കെ ചെയ്യാലോ, ഞാൻ വെയിറ്റ് ചെയ്തതുകൊണ്ട് എനിക്ക് ദോഷം എന്തെങ്കിലും ഉണ്ടാവുമോ? So the usual fear is of cataracts going into maturity and then complicating. But a mature cataract is one where you can barely see the fingers of your hand close to your face, which is far away from early cataract. Of course, all of us, when we do phacoemulsification today, which is the new modality of cataract surgery, find it easier when the lens is less hard. And as the cataract matures, the nucleus, the central part of the lens, where the fibers are most compacted, will get harder, and they are a little more difficult to manage with the technique of phacoemulsification, which is another reason why we advise surgery. Look, anyway, it's coming down, it's going to get worse. So why not get it done so that you have the benefit of good vision for longer? But it is not a must. So spectacles are a good option for people with cataract if they are reluctant to undergo cataract surgery. And in my day, when I was training, it was the patient who decided when he wanted the surgery. When I couldn't improve his vision with spectacles, and he did not get the amount of vision that he wanted, he told me, "I can't manage, please operate." There was another reason. In those days, cataract surgery was done with a larger incision. It was done with sutures. There were umpteen complications, including the dreaded one of infection, where vision was lost permanently. So many of us played safe and waited till the patient had actual difficulty with vision, quite different from today, where we are more or less guaranteed. Of course, there are the exceptional, any surgery will complicate, but by and large, cataract surgery today is so safe that people now operate as soon as vision comes down, even one line from the normal of 6.6. Probably early, but again, if that's what your patient wants, no harm giving it to him. So I've dealt with some of the surgical options that I have, which I will deal with a little more. Then where would I use medical? And the last, I've said reassurance. And this to me is as important as all the others. Telling your patient that he needn't worry, except, like I said, my diabetic and my glaucoma, I'm much less reluctant to reassure, because they see normally the glaucoma patient, whether he uses his drop or not, has the same vision. And the glaucoma medication costs money. If I'm a retired person, I have to depend on somebody else to get my medicines. And again, there's a lesson that I learned the hard way. I've always had old people living with me and been very happy to have them. And I dread when I will not have them. But my mother-in-law, she was with us, and she was on treatment. And she would say, "Pape, marunnu kazhinju." And without even thinking, I would say, "Kazhinju alle amme, iyade alle vaangirunne." And she would feel so bad. I never meant it that way. I meant, "Oh, but didn't we buy it recently?" Was a flippant off-the-cuff remark, which was so unthinking and uncaring when I think about it, which is what happens to all my glaucoma patients who are prescribed the best, the most expensive drug, who will deny their compliance, who will tell you they've used it. But if you go deeply, they haven't. Because they'll say, "Mon ippa joli illa, monod engana parayana." And along with that, we often prescribe a lubricant. And I've had not very poor, well-to-do patients opt for the lubricant, which does nothing to the glaucoma, instead of buying the anti-glaucoma medication, which costs a lot. So those patients, really, if you want compliance, there's no way other than put the fear of God into them. But otherwise, most of the other diseases will not. Whatever has happened, and they will have to learn to live with many of the others, which is where, when I can't do anything, I would like to reassure. I don't know how long I've been talking, but anyway, again, about presbyopia, glasses have a bad name. I'm wearing not only glasses, I'm wearing the old-fashioned bifocals, which most of you would consider pretty old hat. But like my children have always told me, when they start working, they'll buy me a tree house and a bullock cart, because I'm a Luddite. I'm a person who should have been born and living in another century. I'm so primitive or backward with all this. So if you don't like spectacles, if you believe that spectacles alter your cosmesis, then you can go for contact lenses. You can go for LASIK, which can alter the shape of your cornea. There are newer surgeries. And what is slightly more exciting is eye drops are being tried. Many of them just decrease the size of the pupil. And this helps because, you know, if you don't have your presbyopic glass, all you need to do is screw your eyes and you will see better. All you myopes, if you don't have your glasses, decrease the size of your pupil and you will screw your eyes and you will see better. So that option is being now exploited by using drops, which will decrease the pupillary size to some extent and improve vision. I said there are surgical options for cataract, for glaucoma, but there are surgical options for all these as well, which I had mentioned earlier. A medical, mainly for dry eye disease, which is all kinds of lubricant drops. Every medical company worth its name makes these lubricants. So dry eye disease is primarily a medical managed condition, as is glaucoma, though when glaucoma does not respond like we would like it to the medication, we might have to opt for surgery. So when I reassure my people, what are the things that I should do? Like I told you about my 6 diopter lady who was having only 1 meter vision and told me that, look, I can manage very well. Many patients, when they initially lose vision, and let me start with uniocular vision loss. What happens if you suddenly lose the vision in one eye? Nothing seemingly with reading, but you don't see things on that side. You tend to bump into things on that side. But our bodies adjust very well. You learn quickly enough to turn your head that way and to see what you, because you realize quickly that there are things there that you are missing. But what happens when you lose that side in both eyes, when you have a hemianopic defect, which has come up to the center, and then reading is a problem because you can only see part of the line, you do not see the rest of the line. So when the patient is reading this, if he had a left hemianopia, he will not see the improve. Or when he starts seeing the improve and he comes to coping skills, on the next line, he doesn't see the low. So in these patients, what we advise them to do is to bring, when they're looking at improve, to put a finger on the improve and bring that finger down to low and keep it there, then complete that line and then look to where your finger is and start on that line. Whereas if you have a right hemianopia, to put your finger under the print and to move the finger along and look at the finger. So this is, can't see what? No, you don't have to see my finger. You can see, I mean, I was putting my finger on my screen, but anyway, I guess you know what I'm saying. Move your finger along the line for a right homonymous, move the finger to the lower line and start with the finger in a left homonymous hemianopia. Coping occurs even without us knowing it. I have this patient whom I've been seeing for the last 30 years who developed a disease of the retina that is slowly taking away his vision and he is blind. And even yesterday he called me, he's married, he has got 3 lovely sons. And he always says it's a disease for which we have no treatment. And he said, doctor, I am so happy. He's a philosopher. He will say, I'm so happy. I have learned to adjust. I can manage. Even my little son helps me to move. I feel sorry. I empathize with what he must be going through because he had vision that he lost gradually in both eyes. But the ability of the person to adapt, to cope with visual loss is tremendous. In this context, somebody told me something recently, which I found very interesting. He has a relative who is both blind and deaf. And he told that the person who was recounting it to me said, this person told me, you know, if you lose vision and you lose hearing, the popular feeling is that kannu puvana worse than chevi kakaya. But now that I have both, I realize chevi kakayana kooduthala veshmam. And I agree 100%. Even if you can't see, if you can hear, you know what is happening. If you can't hear, you can see, but you don't know what is happening. So I think losing hearing is honestly probably worse than losing vision, where you can cope in so many ways. And of course, one of the ways is these, what we call the low vision aids. And the other is, if you were liked reading, there are these umpteen audiobooks. So in the UK, like I said, people with age-related macular degeneration, which was very common, would be told the good news is you'll never go blind. The bad news is that you might need a magnifying aid, or you might need, we didn't have audiobooks then, they were called talking books. They were recorded books on tape. So what I started by saying that I wouldn't like to treat the eye. I would like to treat the person who has the disease, who is able to cope, who only needs the reassurance, look, all is not lost, you can still manage. And that as an ophthalmologist, I may not be able to cure his blindness except when it is cataract, but I could relieve some of his symptoms, at least to some extent improve his vision. But every time I could make him feel better after he saw me than when he came to see me. And these, of course, are not my sayings. They're the sayings of the great physicians of yesteryear. So these to me make immense sense. It makes immense sense for whatever disease it is that you are treating. And Krishnan thought I should have a message for all of you as a take home. My take home message is aging is physiological. It's going to come to us. It does not necessarily mean that just because we are aged, we can do nothing. There is still a lot that we can do, provided we do it sensibly, provided we appreciate the limits of what we can do, but not fear doing what we can do. I think that's the big difference between us when we are young and learning to walk, when we're not frightened of falling, hurting, and rising. Whereas now, I agree, as I get older, I'm also dead scared of falling and breaking a bone and being bedridden, which is, I'm sure, to all of you, a very real fear. So with care, please do whatever you can do. And there's a lot that we can, as ophthalmologists, help you with as you age. I would like to thank all of you, as well as my parents, my father for having taught me to think, my mother for having nurtured and brought me up, my husband and my children who have been my fiercest critics and my staunchest well-wishers. I thank all of you, and if this has helped any of you anyway, there's nobody more delighted than me. Thank you so much.
Thank you, ma'am. വളരെ ചെറിയൊരു നേരം കൊണ്ട് വളരെ വലിയ രീതിയിൽ അത് മാഡം അതിന്റെ കണ്ണിന്റെ കാര്യം മാത്രമല്ല, കണ്ണ് മാത്രമല്ല, സൈക്കോളജിയും മനസ്സും എല്ലാം ബന്ധപ്പെടുത്തിയ ഒരു പൂർണ്ണ മനുഷ്യനെ കുറിച്ച് ആണ് മാഡത്തിന് പറയാൻ കഴിഞ്ഞത്. വലിയൊരു കാര്യമാണ്. സംശയങ്ങള്.
Yes, I have a question.
Yeah.
There is a question about a blue light from the cell phone. Alka, I know that it is not good for you, but I think it's got something to do with things inside the brain and whatever. I don't think it's purely to do with the retina and the eye. Let me confess that I've also wanted to read it up. I couldn't offhand give you a very authentic answer to your question on how does blue light. I know that at night, the recommendation is please don't read your tablet. Please read an actual book as you're going to sleep. If there are any questions within my scope, I'm happy to take them. But Alka's yours was a really good question, and I know that I should know a bit more about it.
But if I may speak, I am always worried about this. But the cell phone is so addictive and seductive or whatever that we keep using it. And I once asked an ophthalmologist whether it was do any harm, and she promptly said, oh no, there's nothing wrong with it. You can use it as much as you want. But you do hear about this nighttime and lying down. But apart from that, that's reversible. What I fear is that this blue light, would you think, have you heard of it accelerating macular degeneration, age-related?
I haven't actually, though ultraviolet light is the one that is postulated to cause. And I don't know about the blue light. The light, the question that I've always been asked is, TV യുടെ മുമ്പിൽ ഇരുന്നാ കുട്ടിയുടെ കണ്ണ് കേട് വരില്ലേ? ഡോക്ടർ ഒന്ന് അവനോട് പറയൂ, TV കണ്ടാൽ കണ്ണ് കേട് വരും. Now, my take on that was the light that comes out of the television is visible light. Visible light is the only one that I can focus and use to see, which should be the same as the light elsewhere. But whether there are other radiations along with that, which my eye should not honestly focus. Ultraviolet is to some extent filtered out by the lens, by the corneal epithelium actually, takes away. And the rest of it, some of it is filtered by the lens. In fact, as we get older, the lens develops pigment. And one reason for this is believed to be so that it can absorb the ultraviolet light that is going in. And like I said, cataract patients are less likely to develop macular degeneration than those without. So Alka, maybe both of us will go back to Google and ask about what more. I'm no expert on this.
There is one question. Is there any effect for vision if an individual has autoimmune disease? Say psoriasis, psoriatic arthritis and all.
Yes, actually, the autoimmune diseases, the relationship that they have with the eye is immune-mediated uveitis, inflammation of the iris, the ciliary body and the choroid, or of the sclera. That is the collagen diseases. The sclera is collagen. So the arthritic diseases can be associated, like rheumatoid, with scleritis, and psoriasis can cause psoriatic uveitis. But they are not related, obviously, to aging. The other problem that these diseases have is that they're all treated with corticosteroids. And corticosteroids definitely aggravate or accelerate cataract and can cause glaucoma.
What is the cause of dry eye? How can we manage and process Aravagi? Congratulations. 86, I find it so relevant. Any yoga exercise?
Okay. There is a question on
Dry eye.
dry eye. Dry eye, the ocular surface, like I said, the cornea and the conjunctiva are kept wet by the tear film. Now, as we get older, like I said, the corneal, the surface epithelium secretes water, tears. So like the skin dries, part of dry eye is due to aging. But dry eye, again, certain other diseases can aggravate. Rheumatoid arthritis is one cause for dry eye, can be associated with dry nose, dry mouth when it goes by the name of a syndrome. And there are certain drugs that decrease production, anticholinergics, which are part of psychiatric medications or which are also used as antihistaminics. These can also decrease tear secretion. Otherwise, the tears actually have three parts. This is my problem. If I start taking a class, I don't know whether I'll clarify or make things worse. So there is a lipid layer to the tears. The outermost layer is actually a thin layer of fat, which prevents evaporation. And that comes from glands on the lid margin. So blepharitis is one cause where that secretion might come down. And because that layer is not there, the water evaporates faster. So dry eye disease is multifactorial. There is the evaporative cause as well as the parenchyma, decreased formation or faster evaporation of the tears. So that finally the net result is that the tears are not staying in front and wetting it. I have a question on yoga. I find that a very interesting question because I had a good friend who used to come to me every year for having his glasses changed. And then he came to me once and said, you know, I'm doing all these ocular exercises. Will you please check what's happening? And actually the power had come down. But let me, on the other side, tell you that I had a young child who went to I think it's the Aurobindo people in Trivandrum, who had a course. He had myopia. And the myopia, adinu vendita, there were exercises or whatever. So he went there, and there was a lot of time he had to spend over this. And when he came back to me, his power didn't decrease at all. As he grew taller, it increased about half a diopter from what it was initially. The mother was a bit shattered, but went back, persisted. And then finally she came back and said, Doctor, Kannada Urikya, it is not feasible. I mean, he doesn't have the time to do this and he can't see. And if you gave him the glasses. So my teaching is, Nyangada Shastrathila, the things that have altered for yoga, I'm assuming, is for glasses. Power change with yoga or with eye exercises, I do not know. For dry eye, definitely blinking will help. Maybe if it controls your blood pressure and your blood sugars, it would help you. But I don't know anymore. And I know that when I was in the UK, which is very, very many years ago, there was this book, on better eyesight without glasses, which was poo-pooed and scoffed at by every ophthalmologist I knew. They scoffed at the book and they scoffed at the writer. But I don't know. I mean, till it's proved to me that it cannot be done, I will not poo-poo anything anymore. So my answer is, I don't know. I have no proof other than this one friend whose power seemed to come down, but I'm not aware. So he made me do yoga for a while because my powers were increasing all the time. I didn't do it regularly, so I'm not qualified to comment on whether it works or not.
Is there something like vision rehabilitation for elderly?
Yes, is correct question. Vision rehabilitation for elderly clients.
Okay, fine. Can you please tell me what you meant by rehabilitation?
That's Gautam.
Gautam, could you unmute and tell me what
Yes,
you
ma'am.
have in mind, please?
Yes, ma'am. Yes, ma'am.
Ah.
You see, in some cases, some studies are coming when there is no scope for medicine, surgery, and all. That is something with the patient that they give a orientation to their living settings like that.
Yeah, that is what I would call coping. Okay, so we have, if you're losing vision, the two things that we can do to improve, when low vision is where vision hasn't improved to the level I want. So one is vision enhancement. I try to improve it, say by a magnifying aid or telescopic aid. But when that doesn't work, then the next is vision substitution. That is, I give a stake so that you can find where the things are, or I give you a guide dog and help you to cope with that loss of vision. It's a good question. Of course, there is one last thing that is happening, which costs the earth and is not available in India, which my patient that I talked to you about earlier is hoping he will. We are now trying to bypass, if the visual loss is from the retina, we are trying to bypass the retina with a little microchip and then connect it to a computer, which then directly connects to the optic nerve. And of course, you might have heard of this, the bionic eye. Look it up. As of now, it costs the earth. It has complications. It's rather advanced, involved surgery. And it doesn't give you very good vision yet. But as the chip improves in its pixel quality, maybe it will someday help to replace.
Advantage of using progressive.
There are many messages which are appreciating you, ma'am. And there is
Actually, Dr. Subhadra, I'm also seeing the chat box.
okay.
So I think I will take the question, and thank you everyone for the appreciation. It's always feels very good to be appreciated. There's a question about progressives. Now, a progressive, I have a glass which is a bifocal. So my top part of my glass, I see for distance. The bottom part, I see for near. It does not mean that I don't see anything in between. I see sharply and clearly for distance and for near with these two parts. In between, I can definitely see, but I would not be able to make out small differences or how do I say, I would not have that kind of visual acuity. So the ophthalmic indication for a progressive is where you need to see clearly and sharply for distance, for near, and for a distance in between. So if, like I'm now sitting in front of a desktop computer and I want to read small print on that, I have to come up to it. I have to lift up my chin so that I can look through the bottom bit. And because my bottom bit has power for near, I have to go closer to the screen. Whereas if I had a progressive, I could sit straight here because somewhere in between the top and the bottom would be the power that I would get to see there. The second lot of people who can benefit from this are the carpenters who need to see well for far away. They need to see clearly and they need to see clearly for near. And the last, of course, are the people who need to read a music score or a music sheet which is kept far away from you. So you need to see that, you need to see the audience, and you might have to look at some note in your hand. So if you need to see multiple distances equally sharply, it's not that people with bifocals don't see anything in between. They will not see it as clearly a progressive. But of course, today the reason for buying a progressive is partly cosmetic, so that you no longer look your age, even if you start feeling it. Anyway, I mean, that again, I'm happy to look and feel my age, I guess. So I'm happy, whereas my husband loves his progressive. And let me repeat that also. There are a few people who just don't like progressives, who can't adapt to the progressive. I tried progressive. It's not that I didn't, but I'm so happy with my bifocal, and I could not adjust to my progressive. Mind you, progressives cost money, but I got them all free. All my glasses come to me free. So it was not the cost that was the deterrent. It was the fact that I didn't adjust to them. That
And
was
there
the
will be
problem.
people who don't like the bifocal.
Yeah? No, I don't. Anyway,
Silly patients, eye
Allah,
complications.
there is somebody who is 40 and my doctor said I have a dry eye. Let me say that if you don't have dry eye symptoms, I wouldn't worry. There is no way that other than the known causes of dry eye disease, which I could reverse, the lack of secretion very many times I cannot reverse. And unless, of course, I'm seeing now younger people with very bad dry eye and complaints who are really miserable because of their dry eyes. But many times the dry eye is mild. And like I said, just blinking, using the lubricant, and the lubricant has no medicine in it. So you can use it as often as you want and as long as you want. Does that answer your question? Maybe you have dry eye, but it's not the dry eye that you should worry about. It's the symptoms from the dry eye. Or if you have a cause for the dry eye, like say blepharitis or something else that we could treat and improve for you. And if you're using antihistaminics for some kind of allergy, maybe you should try cutting down on that. Maybe you should use only the minimum that you need, not just keep using it as a prophylactic.
There was one more question on in SLE patients, what are the eye complications? Because there is a teacher who is asking about a student. She is complaining, a student who is complaining about headache and some visual problems.
If left to myself, I would think that the headache with not seeing clearly and the headache that comes on after the use of the eye. So eye strain or asthenopia are symptoms that are present only when you use the eye, the headache, the tired feeling in the eyes, the itching, the watering. If they come on after she's been reading and she also is not seeing clearly, it could be related, but the ways in which SLE causes visual loss are not because of a refractive change. But the SLE patient on steroid could develop myopia. So steroids given can cause diabetes and can cause sudden onset of myopia, which again happened to one of the patients referred to me by the dermatologist, who was on some skin condition on steroids, and he was so upset because suddenly he found he was not seeing in the distance. And I didn't know this, and he said he was using the steroids. So I said, have you checked your blood sugar? He said, I was never asked to check my blood sugar. So I said, okay, check your blood sugar. And it was sky high. And I said, bring that down. And sure enough, within a week, the vision reverted. So all of you who are giving patients steroids, high dose, short term, long term, please be aware that when it causes diabetes, along with that, high blood sugars immediately cause refractive change, usually myopia, which is why anybody who's diabetic and needs a glass change, we ask them to first bring down their blood sugars and come with normal sugars. Or the glass I prescribe today may be no good a week later. So SLE patient headache, there are so many other complications of SLE, I know. So maybe her eyes need checking, and if she needs glasses and that gets rid of it, maybe she had a refractive error quite unrelated to this. I've become like the oracle on all diseases of the eye. I agree, over these years, I do have a fair idea of many things, but I am as much a learner in many things as many of you. Would that be all then?
I think it's, yeah, the questions, I think the questions are over. Is there anybody who wants to speak or ask questions? I think it is over. There is one question mentioned as dogs and coping. I don't know what the...
Dr. Sarah, I think you were asking, can dogs help you to cope, Nana? Actually, dogs are a man's best friend. And when you can't see a guide dog, you will find that in the West, even here, I'm sure there are people with dogs. Dogs are more company and friend than actual human beings. And for people with disability, visual disability, dogs are a great boon, actually. They will fetch things for you, they will protect you from harm, and they will guide you when you're walking. Make sure that you're safe.
Okay, ma'am, I think the questions are over. So we can...
Yeah, I think for once you can finish early.
Yeah.
Track it.
അങ്ങനെ നട്ട്ഷെല്ല് പറയുകയാണെങ്കിൽ മാം ഒരു വിഷൻ എന്ന കൺസെപ്റ്റ് മൈൻഡിലാണെന്നാണ് മാഡം പറഞ്ഞു വെച്ചത്. നോർമൽ എന്ന് പറയുന്നതും ഓരോരുത്തർക്കും ആയിട്ടാണ് മാഡത്തിന്റെ ഒരു കൺസെപ്റ്റ് മാഡം പറഞ്ഞു വെച്ചത്. എല്ലാവരും അതിനോട് അഗ്രി ചെയ്യുമോന്ന് അറിയില്ല. പക്ഷെ മാഡം അത്രയും സബ്ജക്റ്റീവ് ആക്കി വിഷനെ ആക്കി എടുക്കുകയാണ് ചെയ്തത്. അതുപോലെ മാഡം കുറെ കണ്ടീഷൻസിലൂടെ പോയി, ലൈക്ക് ഡ്രൈ ഐസ്, ലിറ്റ് ചേഞ്ചസ്, വിഷൻ പ്രോബ്ലംസ്. അതുപോലെ തന്നെ ഇതിൽ ഏറ്റവും വലിയൊരു മെസ്സേജ് ആയിട്ട് മാഡം അതിനിടയിൽ പറഞ്ഞിരുന്നത് ഡയബറ്റിക് കണ്ടീഷൻസിനെ മാനേജ് ചെയ്യാൻ മറക്കാതിരിക്കുക. എത്ര തന്നെ പിന്നെ എന്തൊക്കെ കണ്ടീഷൻസ്, ഡയബറ്റിസ് എപ്പോഴും മാനേജ് ചെയ്യുക. ഡയബറ്റിസ് മാനേജ് ചെയ്യാൻ ആദ്യത്തെ 5 വർഷത്തെ ഡയബറ്റിക് മാനേജ്മെന്റ് തന്നെ മാഡം പറഞ്ഞിരുന്നു വിഷന്റെ കാര്യത്തിൽ വളരെ വലിയൊരു എഫക്റ്റ് ഉണ്ടാക്കുമെന്ന്. പിന്നെ അത് കൂടാതെ പറഞ്ഞിരുന്നത് പിന്നെ റെറ്റിനോപ്പതിയെ കുറിച്ച് പറഞ്ഞിരുന്നു. ആൻഡ് വാട്ട് ക്യാൻ ബി ഡൺ, ലൈക്ക് യൂസിങ് സ്പെക്ടക്കിൾസ്, അബൌട്ട് ദ സർജറി, ആൻഡ് അഗെയിൻ again, ma'am mentioned about the reassurance, which he mentioned very strongly. Reassurance by improving the coping skills. And also she mentioned about audiobooks. And again, one more thing she mentioned, hearing loss is more important when compared to the vision loss in coping skills. So these were the important topics, important concepts you had gone through. I think we can wind up. And
Dr. Subhadra, can I just, I like to have the last word probably. Can I just say two things? One is normally what worries me is each of us defining us as normal. In fact, I'm making a plea that we understand that we are not the normals. We are not necessarily, but along with that, what I'm saying is that all of us needn't be 5'5" or weigh 72 kilos or have a blood pressure of 120/80. So I'm saying the normality that we define for most of us is not a must, but normal, when I say normal in inverted commas, when all the time we fight, no? Because why do we fight? How could you think like that? How could you say that? How come she walks like that? How can she dress like that? Why not? To her, that is her norm. I'm asking for a level of tolerance where normal is not me. Normal could have so many dimensions and so much more to it. And when I come to reassurance, I'm sure Dr. Shaji will agree with me on this, that talking to a patient, listening to the patient, giving a patient the chance to ventilate all that is worrying him takes away so much, and saying, look, this is all it is. I wouldn't worry. It's not going to, because the fear is not of the dry eye symptom. The fear is that this is something that is going to take away your vision, that's going to make you blind. And the same thing, there are so many, maybe I should say this also because there is a time. My mother and my father never used glasses, okay? And their coping skill was using their iPads and increasing the font size. So the, the contrast on their device, as well as the ability to increase the font size. And I never insisted because I'm 100% certain that not wearing the glass will trouble you. You might have problems, but it's not going to take away your vision. My siblings, who are the one who's just a year younger to me, never used glasses for reading till she was 50. And she now uses a glass that I would normally prescribe at 50 when she's past 65. Okay. Now, in their case, they never used their lenses continue to mold. What did I do at 40? The minute I couldn't see, I got my pair of glasses. 2 years later, I thought, no, this is not good enough. I'm not seeing near enough. I changed it again so that in my family, I am the only person who is totally glass dependent, wearing 5 diopters to see clearly for near. So that is my next thing, that if you have presbyopia and you're coping, however you're coping, cope. Not wearing the glasses will not make you blind. And of course, the last I was saying about reassurance is please listen to your patient, because patient after patient will tell me, I'll say, no, Ilya, if you want, I'll write for you something, but I didn't think there's anything wrong. And they'll say, Adu madi doctor, ningal onnu ezhudanda, ningalodu samsarichappo thanne ende asugam mari. And like I said last time also, I come away feeling like the worst quack because I've done nothing. I've only talked, I've only looked, I've only reassured. But that is what many of our patients ultimately need. And it happened to me. I've had pains. When somebody tells me it will go away, believe you me, it does go away. Krishnan says not only seeing, but everything else is in the mind. I'm sure Shaji will also agree, and it's very, very true. It's how you feel about things that are your reality, not what you read on the chart. Thank you very much. I think I will stop.
എനിക്ക് തോന്നുന്നു മാഡത്തിന് അനവധി പിന്നെ പ്രൈസസ് ഉണ്ട്. മാഡത്തിന്റെ ഫാൻ ഫെയർ കുറെ കൂടിയിട്ടുണ്ടെന്ന് തോന്നുന്നു മാഡം. നന്ദി പ്രകാശിപ്പിക്കുക എന്ന ദൗത്യത്തിലേക്ക് ഞാൻ കടക്കട്ടെ. ഇത്രയും നേരം ഇങ്ങനെ ഒരു വിഷയത്തിൽ ഇത്ര സുന്ദരവും സരളവുമായ രീതിയിൽ പ്രഭാഷണം നടത്തിയ പത്മജ മാഡത്തിന് ഞാൻ സെന്ററിന്റെ പേരിലും സ്വന്തം പേരിലും നന്ദി അറിയിക്കുകയാണ്. മാഡത്തിന്റെ പിന്നിലിരിക്കുന്ന കൃഷ്ണൻ സാറും അതിന്റെ നന്ദിയുടെ ഒരു ചെറിയൊരു ഭാഗം അർഹിക്കുന്ന ആളാണ്. സാർ അവിടെ ഇരുന്ന് ഓരോ മെസ്സേജസും സാറ് തന്നെയും കൂടെ വായിച്ച് സഹായിക്കുന്നുണ്ടായിരുന്നു. സാറിനും താങ്ക് യു സർ. ഈ പരിപാടി നടക്കുവാൻ അനുമതി തന്ന് ഉദ്ഘാടനം ചെയ്ത ബഹുമാനപ്പെട്ട VC മോഹനൻ സാറിനും ആശംസ അർപ്പിച്ച PVC വിജയൻ സാറിനും രജിസ്ട്രാർ മനോജ് സാറിനും യൂണിവേഴ്സിറ്റി സ്റ്റാറ്റ്യൂട്ടറി ഓഫീസർമാരായ ഡീൻ റിസർച്ച് ഷാജി സർ, ഡീൻ അക്കാഡമിക് ഉണ്ണികൃഷ്ണൻ സർ, ഡീൻ സ്റ്റുഡൻസ് അഫയേഴ്സ് ഇക്ബാൽ സർ, കൂടാതെ ഇതിന്റെ പിന്നിൽ പ്രവർത്തിച്ച IT മാനേജർ ഹെർലാൽ സർ, അജിത്, എൻ്റെ ഓഫീസ് സഹപ്രവർത്തകര്, പിന്നെ JR ഗീത മാഡം, ഇങ്ങനെ കുറെ അധികം പേര് ഇതിന്റെ പിന്നിൽ പ്രവർത്തിച്ചിട്ടുണ്ട്. അവർക്ക് എല്ലാവർക്കും ഞാൻ എൻ്റെ നന്ദി അറിയിച്ചു കൊള്ളട്ടെ. കൂടാതെ ഇതിൽ പങ്കെടുത്ത് ചർച്ചകളിൽ സജീവമാക്കിയ ഓരോ വ്യക്തികൾക്കും നന്ദി പറഞ്ഞു കൊള്ളട്ടെ. ഇത് കൂടാതെ ഒരു കാര്യവും കൂടെ അറിയിക്കട്ടെ. കൂടാതെ ഫെബ്രുവരി 25 വൈകിട്ട് 7 മണിക്ക് ഏജിങ് കിഡ്നി എന്ന വിഷയത്തെക്കുറിച്ച് ഡോക്ടർ തോമസ് മാത്യുവിന്റെ ഒരു പ്രഭാഷണം കൂടെ ഉണ്ടാകുന്നതാണ് എന്ന് അറിയിച്ചുകൊണ്ട് ഞാൻ നിർത്തട്ടെ. നന്ദി, നമസ്കാരം.